We have one bill that we're going to be taking up. It's Senate Bill 2799, the infamous tech bill. Most of you were here during the summer when we had our joint committee hearings with the House, and we brought in, I think there were 22 different provider groups that came in over 4 days and expressed their kind of their wish list, if you would, as to what they would like to see in the tech bill. Over the course of the last few months, we've met with some of the different groups. We've met with the department, and I think we've come up with a bill that's going to basically be moving the ball forward, or moving the ball down the field, as they say. I have provided you with the deleted text version of the bill because I wanted everybody to be able to see what we deleted, what we've added. I know it's kind of confusing. Sometimes we have these committee meetings and we don't know what was taken out, and what was taken out was sometimes more important than what we put in. I'm just going to give a brief overview because I imagine after this you'll want to review this, and certainly when we have our discussion on the floor, I'm sure and would anticipate there'd be more questions. So just briefly, nursing facilities services, and this is specifically line 170, we made changes to the therapeutic home leave days. We actually decreased the number of days and changed full payment to partial payment. And actually under the partial payment, it's not to be less than 50%. Under the current law, the division makes a full payment to nursing facilities not exceeding 42 days per year, and those do not include the major holidays. So this change states that the division shall make partial payment an amount not less than 50% of the per diem rate to nursing facilities not exceeding 35 days per year, not including major holidays. Another section we addressed, and that's line 257, is basically some technical editing cleanup. More clearly states that physicians are to be reimbursed at 90% of the rate established on January 1st, 2018, and may be adjusted under Medicare. It does not lower the reimbursement rates for these physicians. Intermediate care facilities, line 395. We made changes to the therapeutic leave days. We actually increased the number of days for these folks, but we did change the full payment. Under current law, the division shall make full payment to ICFs not exceeding 63 days per year, not including major holidays. This change states that the division shall make a partial payment in the amount not less than 50% of the per diem rate to ICFs not exceeding 70 days per year. So we actually increased that. Clinical services, line 436. This is new language to clarify what clinical services means under federal law. Preventive, diagnostic, therapeutic, rehabilitative, or palliative services that are furnished by a facility that is not part of a hospital but is organized and operated to provide medical care to outpatients. Clinical services included but not limited to services provided by ambulatory surgery centers and dialysis centers. We actually included the ASC language just to make clear that we intended for them to be covered under clinical services. Hospital assessment, line 501, we authorized an ambulance upper payment limit. We authorized a physician upper payment limit for physicians who are not employed at public hospitals, but at private hospitals as well. Line 698, we added new language that would require the division to recognize FQHCs and RHCs and local health department clinics as both an originating site provider as well as a distant site provider for telehealth reimbursement. And why do we do that? Well, under current COVID-19 emergency orders, they've been recognized as both originating and distant site providers. This is going to allow them to continue to get reimbursement at both ends for the services that they're providing. Inpatient psych services, line 726 to 729. We added new language that would ensure the division is able to reimburse for services provided by a licensed freestanding psych hospital to recipients who are over the age of 21 in a manner consistent with the waiver program. Vaccines for beneficiaries aged 10 to 18. This is lines 968. It adds language requiring the Division and Department of Health to notify OB/GYN providers that the Vaccines for Children program is available to providers free of charge. And the reason we're doing this is there was an issue that came up, if you recall, during the hearing. One of the OB/GYN providers said that they could not give a flu shot to a 16-year-old who was undergoing treatment for pregnancy. As we investigated, we found out that the Vaccines for Children program is free to providers, and instead of getting deep into legislation, we are just asking the Department of Health to notify OB/GYNs of this service. Bariatric surgery, line 972, it adds bariatric surgery as a covered service. We're one of the few states, in fact, I think we're one of 3, possibly 2, that do not provide that service. So we're going to attempt to provide that, and the department is to provide a report back on the efficacy of that program. Postpartum coverage, lines 974 to 985. It expands postpartum coverage from 60 days to 12 months. It's the intent of the legislature that the division shall reduce the application time and simplify application procedures for pregnant women applying for Medicaid coverage postpartum. Not sure if you guys know, but currently for a pregnant woman, they're usually about 60% way through their gestation period before they can get on Medicaid. That's just not acceptable. Under the COVID extension, we're currently having to provide these services unlimited. Right now, there is no time limit. So we're going to go ahead and this was another big ask by a lot of folks. When you take a look at our infant mortality and our maternal mortality, it almost becomes a no-brainer for us to offer this service. So we're going to expand those services. The 5% assessment, that lines 986 to 1027, it deletes the 5% assessment on providers that current law requires the division to reduce reimbursement by the 5%. So community mental health centers, DME providers, ambulances, dentists, and ambulatory surgery centers are going to see a 5% increase in reimbursement. And again, that was another big ask when we met with providers. Managed care, lines 1090 to 1103. It deletes the 45% enrollment cap on managed care. Basically, what it's going to allow the department to do is to roll, eventually, if they decide to enroll CHIP and family planning waiver and Healthier Mississippi waiver recipients into the managed care program. The intent is hopefully it can reduce our cost as we get some healthier population into the Medicaid mix or the managed care mix. Level of care guidelines, line 1146 to 1154, adds additional language that requires the division to implement level of care guidelines and the determination of medical necessity in all utilization management practices, including prior authorization process, concurrent reviews, retrospective reviews, and payments. Another big ask by the providers. Lines 1238 to 1240, we added some language that each managed care contractor shall disclose to both the House and Senate Medicaid chairman their administrative expenses and costs for prior year, calendar year, and the number of full-time equivalent employees located in the state. We also added some language to reviews and audits to make an independent third party, plural, so that one can conduct an audit or review. And the review shall include, but not limited to, at least 2 of the current law requirements for the audit. Lines 1303 to 1309, uniform credentialing. If you'll recall, this was another major ask by the providers. This requires the MCOs to develop a uniform credentialing process to be in place by July 1st of 2022. If they don't, the division shall establish a uniform credentialing process. As we looked at this particular issue, it's more to it than just throwing out a piece of paper saying fill it out. The managed care folks are all operate in states that currently have some form of single or uniform credentialing. So we anticipate it won't take long. It's going to involve the department getting with the hospital association and the different provider groups, getting some input into the process. And it is my hope that once this passes, we'll be able to talk to the Department of Insurance and maybe have them adopted statewide. Lines 1318 to 1320 and following, it's the intent of the legislation for the division to evaluate the feasibility of continuing to administrate pharmacy benefits under fee-for-service. It's also the intent of the division to evaluate the feasibility of utilizing a single vendor to administer dental benefits provided under managed care, and also the intent of the legislature and managed care that managed care shall implement innovative programs to improve the health and well-being of members diagnosed with pre-diabetes and diabetes. Lines 2532, 2534 deletes a 27-year-old moratorium on child and adolescent psych beds and chemical dependency beds. Lines 2961, 2982 deletes the requirement that in order for a post-acute residential brain injury rehab facility to receive a license, the facility must agree in writing that they will not participate in the Medicaid program or will keep and admit any patient in the facility who participates in the Medicaid program. Currently, there's only one facility in the state that offers this service, but right now we're sending recipients out of state at additional cost for this service. As you look at some of these rules, you kind of scratch your head. What were we thinking when we came up with this stuff? The next one is another example, 3068 to 3071. It deletes the 2 or more hospitalizations in the last 12 months requirement for someone to qualify to receive remote patient monitoring services. And then lastly, there's some examples of increased division had asked to deal with a number of things administratively. So the examples of that are increasing reimbursement rates for applied behavioral analysis, coverage for individuals with autism, speeding up state fair hearing process and appeals. Uniform credentialing has 1 year being put in place, as we talked about. And that's why I'm going to have a 1-year repealer in the bill instead of a traditional 3-year. I think my personal view is that by having that 3-year repealer, it gives us, it puts us on the legislature side we kind of kick the can down the road every 3 years to deal with the projects. You got an issue? I'll deal with it in the repealer in a couple of years. I don't think that's right. The healthcare moves is too fluid. There's too much going on. We also have a new administration in Washington that who knows what we might have to be able to be in a position to react to. And thirdly, you heard me mention that the department has agreed to do a number of things administratively. So in essence, holding their feet to the fire, make these changes or else we'll have to come back and legislate some. So anyway, that's an explanation of the bill. Be happy to answer any questions. Senator Bryan?
I can ask you a question about what the legislature was thinking when they adopted certain provisions.
Is that in the form of a question? Would you like, you want to elaborate? Thank you, Senator. Senator Parks?
On line 1143, it says all Medicaid beneficiaries with hemophilias shall receive unrestricted. That's all been taken out. Is that covered someplace else? Is it a different piece of language that would cover?
I'm sorry, what line?
1143 through 1145 has been removed. It's the benefits for the hemophilias,
Oh, okay.
unrestricted access
Yeah.
to
Yeah, I can answer that.
Is it falling under some other type program or?
It is, in a number of these deletions, there's a lot of cleanup language that occurred throughout the bill that I just didn't want to get into, but we'll be happy to at your request. But let me find the hemophilia language here.
It's, in the bill, it's on 1143 through 1145, but there may be some other place
Yeah.
that this is covered now.
Okay. These proposed changes deletes that these beneficiaries shall receive unrestricted access to anti-hemophilia factor products through non-capitated reimbursement programs. And currently, a beneficiary with hemophilia is automatically carved out of managed care and enrolled in fee-for-service. And according to the department, managed care offers better care management for high-cost beneficiaries that would allow these members access to more services.
Okay,
So that's why we
so it is
we took
covered,
that.
okay. All right.
Yes, Senator Blackman.
Thank you, Mr. Chairman. Did I understand you to say that this was going to be for a one-year period?
Yeah, well, there's going to be a one-year repealer instead of the traditional 3-year.
Okay, but it's not in this here proposed committee, sir?
Yes, ma'am, it is.
Where is it at? Okay.
1703.
Okay, so it'll be from and after passage, but from, okay, so if it passes next week in the House, then it'll be a year from when it passed.
Yes, ma'am. So
Okay.
we'd basically take it up again next year.
Okay, my other,
And at that point in time, I think we can either extend the repealer or continue with another one-year, one-year term repealer, or we could extend it to a 3-year repealer.
okay, I attended all of those hearings across the summer of 2020, and they were most helpful. Did we provide for the increase for dental services for children?
Yes, ma'am. The dentist will get a 5% increase.
And what about for prescription drugs, for brand name drugs as opposed to generic?
We didn't address that specifically.
And was there a reason for that?
Just, we made a lot of changes, I think positive changes, trying to hit on what most of the providers had I guess, represented were major issues, and we just didn't get to the prescription drug as far as extending those brand names.
And did we allow for telemedicine treatment for recipients for attention deficit hyperactive disorder?
Yes, ma'am. The department's going to be addressing that administratively. That was one of those items they requested to do, and again, the reason for the one-year repealer.
So we'll see if they did it, and if they don't, then we'll do it statutorily.
That's possible.
What about and I remember, I think it was the OBGYN who testified about that long-acting reversible contraceptive.
Yes, ma'am. There is a program for that, and I don't have a complete answer, but it is available, and I'm not sure why it's not being utilized more often. And that's something we can take a look at and find out a little bit more before we do the floor presentation.
And the elimination of the waiting period for services for those with brain or spinal cord injury, did we address that?
The waiting period, that I'll have to look into.
I think those are the only ones I remember from the hearings. Thank you, Mr. Chair.
Welcome. Any other questions? Senator Blunt?
Thank you, Mr. Chairman. A lot of changes, particularly as it relates to providers and how they're reimbursed in programs that would be added or subtracted. Do you have a sense of the overall physical impact of this bill? How it will affect the state Medicaid budget?
About 19 million,
So
state share.
So we project, if what you have in this bill had been in place for this budget year, the net increase in cost to the state with all the changing of reimbursements for dentists and hospitals and providers and all that stuff is estimated at 19 million?
I don't know about this fiscal year. I'm talking about for next fiscal year. We anticipate being about 19 million.
More than if we just simply extended the program as it stands today.
Correct, versus doing nothing. But if you take a look at, I think certainly we have to have advances in the healthy outcomes of our constituents.
Mm-hmm.
You take a look at our infant mortality rate. You take a look at our maternal mortality rate. You take a look at our mortality rate as it relates to diabetes and hypertension, obesity. These are all some things that we're trying to address so that we, in hopes, can improve the health of our citizens and not be number 50 when it comes down to a lot of these issues.
Well, I certainly agree with that, and a lot of those people you're talking about don't have health insurance. So is there anything in here? I thought the hearings that we had last fall were very informative, and we heard from a lot of different people. But I want to say everybody that we heard from were providers who get paid. We didn't hear from anybody who's a patient, who's a customer, who doesn't have Medicaid, who might have Medicaid if we looked at this differently. Is there any, so some people are going to get paid more money, but is there anything in here that's going to provide more access to care than what we currently have?
Well, absolutely. We talked about the postpartum. We talked
Right.
about the bariatric surgery. We talked about the brain injury folks. We talked about telemedicine.
Mm-hmm.
We talked about
I'm sorry if I wasn't clear in my question. I mean,
there were a number of things. We're talking about expansion for mental health services. So yes, I'd say we have expanded the opportunity for our citizens to have access to additional services.
for those who are eligible for the program.
Yes, sir.
Right, okay. Is there anything in here that will deal with the uncompensated care problems that we have for many of our providers?
If you're talking about expansion, no.
No, I'm not at this time talking about that. I'm talking about, is there anything else in here that deals with, so the population of people who are eligible to receive the programs you just talked about, bariatric surgery and everything else, is the same population that we have today. So if a provider's eating a cost for treating someone who doesn't have health insurance, that they can project that same situation going forward.
At this time, yes.
Okay, thank you.
You're welcome. Are there any other questions? I'll entertain a motion then. Motion is titled Sufficient Due Pass. All in favor? Aye. Opposed? Appears the ayes have it. Thank you. We'll report the bill.